alaikum. Good evening, everybody. Ramadan Mubarak for you all, and welcome joining us today in our meeting about ITB. Thank you for being here at this time of Ramadan. Hopefully you will have all informative and fruitful meeting, especially with we are having a distinguished speaker today joining us, who are well known in the field. I'm Iman Al-Hazmi, hematology consultant at King Fahd Armed Forces Hospital in Jeddah. I would like to start our meeting without a delay. I could see we have a great number of attendees, so I believe we can kick off our meeting for today. So we keep up with our schedule without a delay. So we'll start first by welcoming our first speaker, Dr. Drew Brovan. He's a well-known hematologist and a presentation coach. Dr. Drew have multiple publications, more than 80 articles in peer-reviewed journals, and more than 20 books, educational books. He's been appointed as a senior consultant hematologist for almost 11 years, 5 years and 6 years in a row. So 2 times. He will start our meeting today discussing, So we'll start first with Dr. Drew, and he will talk to us about navigating ITB treatment in 2021. Join me, please, to welcome Dr. Drew.
Thank you, Dr. Iman, and Ramadan Mubarak to all of you, friends and colleagues. It's always a pleasure to speak to you. It's a shame it has to be virtual this time, but eventually we'll get together again when the pandemic is over. So let me hopefully share my slides with you, and I hope you can see these. If they don't move, please tell me. I gave a talk 2 weeks ago, and the slides didn't change for the audience, but they waited for 5 minutes before they told me, so anyway, hopefully it will change. Here are my disclosures. So what I'm going to cover in this short session, it's not very long. I'm going to talk about ITP very briefly and the quality of life, and then look at the older therapies and some of the problems with those drugs, and especially in a pandemic, these are not great drugs. I'll be talking about TPOs, of course, sustained response, that kind of thing, and then I'll pick out a few things from the guideline. I'm not through all the ASH guidelines. I'm not going through all the consensus. I'll just pick out a few things that I think are useful today. So ITP is autoimmune, as you know. We don't understand the cause. There's platelet destruction and an underproduction problem, which is why the TPOs are so useful. And it's isolated thrombocytopenia with a platelet count less than 100 nowadays, because platelets between 100 and 150 is not a disease at all. It's just borderline thrombocytopenia. There should be, in primary ITP, there should be no detectable cause. And the problem is this disease is incredibly variable in its clinical features. You can either have no symptoms or be seriously unwell with major bleeding, or in between. And that's the problem with this disease, is knowing what will happen to a patient. And because of this variability and the clinical features that we see, like widespread, this is one of my patients, widespread petechiae, purpura going right up to the abdominal wall, bruising caused by a sport injury, which is not fatal, but it is alarming, and then the occasional intracerebral hemorrhage. And this last complication is really what has driven us to overtreat for decades. We're so scared of someone bleeding into their brain that we treat lots of people to prevent the occasional disaster. And that's a problem with ITP. And there's no really good way of predicting this event. So that is an issue for this disease. The old treatments, I mean the old immune suppressing therapies, corticosteroids, dapsone, danazole, they affect the quality of life. And we'll hear more about this later, I'm sure. The quality of life is not good on these old drugs. Now, this disease is a low morbidity disease. Not many people are unwell. It's a low mortality disease. Not many people die, which is a good thing, of course. And the management is easy. For most patients, the management is very straightforward and easy. But sometimes it's difficult. In 10% or maybe 15%, the management is much more difficult. But for the majority of patients, it's a very easy disease to manage. And we know that these old treatments, again, we will hear about IVIG later, it's quite clear these old treatments are not good. And this is what we did until the TPOs were available. We used steroids from the 1950s. We used chemotherapy drugs, azathioprine, cyclophosphamide, vincristine, danazole, anti-D, rituximab. And all of these drugs are empirical. There are no randomized trials, but this is all we had until Nplate and Reveille. This is all we had. So we had to use them. And they have lots of side effects, which I'm not going to go through. It's very boring if I did, but they have lots of side effects and the efficacy is not great for these drugs. Let me just pick two of these drugs, or one of these drugs and one other treatment, rituximab. We used this for a long time. Before the TPOs, we loved rituximab. Response rate 60%, that's okay. Long term, it's no better than placebo. If you look at rituximab in red with placebo in green or blue, they're really much the same. If you look at the long-term outcome, there's nothing very different. P-value 0.6. That's if you give rituximab in a non-selective way. But if you give rituximab to young females, which is the red line, and compare that with everyone else having rituximab in the dotted line, then the females have a sustained response and a stable response that's much higher, much better than giving it non-selectively. So rituximab, maybe, I'm not saying don't use it, but maybe keep it for certain circumstances, young females, the short duration ITP. Splenectomy, I don't want to go into detail here. Splenectomy has got lots of complications. The rate of splenectomy has fallen from around 30% 20 years ago. It's now about 3% because of the TPOs, really. So we have a new way of managing ITP, which has really evolved over the last 10 years, driven by the introduction of the TPO receptor agonists. We realize that ITP is really not very dangerous. As I said before, very few people die from ITP and not many people are unwell from ITP. So it's not that dangerous. And we have been overtreating patients. So now we are much more relaxed in the way we manage this. We are trying to use less immune suppression, which in a pandemic is a very good thing. Immune suppression use has gone down anyway, but because of COVID-19, it's gone down to quite low levels. Corticosteroids, we're using less and recommending that we use short courses of corticosteroids. We're really aiming to maximize the quality of life of the patients. That's the most important part now. It's not the platelet count. We're not going for some magical platelet count. We're trying to keep people well and stop them from bleeding. So we've rethought all the goals of therapy. We've had a rethink about our treatments, and we're also developing new treatments. So at the moment, as you know, we're in this global pandemic. Immune suppression in terms of treatment is not really an ideal therapy. If you can avoid immune suppression, then it should be avoided. But we've got more modern therapies like the TPO receptor agonists, Revelade, Nplate, and they do not suppress the immune system, and they have incredibly high efficacy, unlike the old empirical therapies. The efficacy of the TPOs is really high. So we're in this evidence-based era at long last for general benign hematology. No longer do we have to rely on untested treatments. We can now use drugs which have undergone large randomized clinical trials. Eltrombopag, romiplostim, we've been using for 10 years or more. We have fostamatinib now approved worldwide, avatrombopag as well, and then we have other drugs coming beyond those drugs. So it's a much better time for patients than before. Now, this is taken from the consensus guideline, and this is our approach to therapy. Initial treatment, which is really the old first-line treatment, is still steroids, IVIG, pretty much. And then if you require something else, it's called subsequent, not second line, subsequent. And we would recommend people look at the drugs where there's a yellow shape around them: eltrombopag, romiplostim, avatrombopag, the TPO receptor agonists. If these don't work, then there are other drugs. There's the less robust evidence drugs as well, and a splenectomy at some stage if that is deemed to be the right treatment. So let's have a quick look at the TPO receptor agonists. We have 3 worldwide. Not every country has all 3, but there are 3 approved worldwide. Eltrombopag, you know very well. Romiplostim, you know very well. Avatrombopag is new. The licenses are different for each drug, which is a problem in a way. Eltrombopag is approved for adults with primary ITP from 6 months. For children over the age of 1 year with primary ITP from 6 months. Romiplostim has had a change in license very recently, and it's for adults at any stage, newly diagnosed, persistent, or chronic. Children with chronic ITP. So both the older drugs are for children and adults. Avatrombopag, the latest small molecule, is only available for adults with chronic ITP. So that is a slight problem, the difference in licensing. Now, these drugs are pretty amazing. They are very, you know this, they're very effective. They bring up the platelet count beautifully. Fatigue, if that was there, disappears. They can go to the gym, go on holiday. Patients feel really good on these drugs. Crucially, the infection risk is very low or zero, because the immune system is not suppressed. The response is usually lasting responses, and the efficacy is 80% or more, and it gets higher the earlier you use the TPO receptor agonist. Now, I will go through these fairly quickly because you know these data incredibly well. It just shows how well these drugs work. The green circles are eltrombopag, the pink squares are placebo. This is a 6-month double-blind randomized study of eltrombopag, the RAISE study. The drug works throughout the whole duration of the study, and then at the end of the study, what I want to draw your attention to is the dotted line on the right, and you'll see the off-study period. The platelet counts go back to baseline for the patients. But that's because the drugs were stopped very suddenly and not tapered. These are bleeding events which drop. The green, again, is drug, and the pink is placebo. Bleeding is less. Not surprisingly, the platelet count is high, so the bleeding is obviously much less. Those patients who came in on the study, and many of them did, on background medication like maybe azathioprine or a small dose of mycophenolate or steroid, they were in 60% able to reduce or stop those drugs, which is really advantageous compared to placebo. It was much higher. But of course, are these drugs safe to use long term? Well, we know now from the EXTEND study, which is the open label extension study for eltrombopag, which goes out now to about 10 years. We know that there are no new safety signals coming out even after 10 years continuous use of L-Thrombopag. So that's really reassuring for us as clinicians. For completeness, I'm showing you romiplostim. Again, this is a 6-month study, splenectomized patients on the top panel and non-splenectomized on the bottom. The splenectomized group are a tricky group. They've had more treatments. The non-splenectomized group have had fewer treatments, but they both respond. They both continue to respond through the study. And when the drug was suddenly stopped, the platelets go back to baseline. Side effects, nothing untoward, no different to placebo. And then the latest drug, avatrombopag, there are 2 studies to note. One is a phase 2 study, a 4-week study, and then one is a longer phase 3 study. And this is from their core 6-month study. It looks very much like L-Thrombopag and romiplostim. And again, their long-term extension study looks like the extended study for L-Thrombopag. So they are all similar in their efficacy and their durability and their safety profile. So these drugs are very effective. They are also very well tolerated by our patients. They like them, unlike the old therapies, which they do not like. The platelet counts rise nicely, and the bleeding, if there is any, will subside. And the quality of life is much better on those drugs. And then we see this unexpected bonus, the sustained responses off, this is off treatment. From the studies, the RAISE study and the 6-month randomized study from Nplate, very few of the patients had a sustained response because the drug was abruptly withdrawn. But of course, in the real world, we taper. But if you taper slowly off treatment for these drugs, it looks around 32.5% can expect to come off their TPO and maintain either a normal platelet count or at least a very good, very safe platelet count. So these data are from romiplostim, L-Thrombopag, and I'm sure avatrombopag will be exactly the same. And I think for these patients in green, the 32.5%, I think their immune system in many cases will have been reset somehow magically through the TPO receptor agonist. And the ITP may have gone away for many of them. This may be curative, but obviously we don't know whether it's cure or not yet. But it would be lovely if we could cure this previously incurable disease. So let me just say a few words now about the 2 guidelines. Well, several guidelines have been published, but these are the 2 main ones. The updated International Consensus Report, which has an expanded group of experts this time round. No one from the Middle East, unfortunately, but maybe next time. But we have China, we have Hong Kong, we have Canada this time round, and we have Belgium as well. Sorry, Norway this time. And then the American guidelines at the bottom, which was solely North America. And these are the key themes from both guidelines. They're very aligned in their thinking and in their recommendations. They both strongly want to limit corticosteroid exposure. They both want to wait before carrying out splenectomy, at least a year. This allows people to have other drugs, maybe to have a TPO receptor agonist like Revolade and have a sustained response and keep their spleen. And especially during a pandemic, we do not want to remove spleens unless we absolutely have to remove a spleen. They both define the treatment goals clearly, and they both consider quality of life very strongly and provide future directions. So I showed you this earlier, this algorithm, such as it is. Initial treatment, we don't use words like first line or second line or third line or fourth line, because when you use those terms, it kind of third line therapy, but we don't have those data. So we simply call the initial treatment and then subsequent treatment. Initial is first line, obviously. Steroids, IVIG. You have anti-D, I think. In the Middle East, we do not. So for us, it's steroids and IVIG. And then in terms of the steroids, this is one of the important things that we added this time round. Because patients hate steroids and because we use them for too long, we thought, let's try to prescribe a way to use these drugs which will not impair the quality of life so much. So we recommend prednisolone or prednisone, 1 milligram per kilogram. We recommend not going above 80 milligrams in patient, even if they weigh more than 80. Do that for 2 weeks. And one of two things will happen. They're either going to respond or they are not going to respond. Now, if they respond, then taper off over 4 weeks. So the total duration of their steroids should be 6 weeks. If after 2 weeks of the full dose there is no response, then simply taper off over a few days. So this is very different to how we used to prescribe steroids. We know of patients who have been on for 3 months, 4 months, 6 months with lots of comorbidities, which then been acquired because of the side effects of the steroids. So this is a big change in our practice, and the American guidelines are very similar. You can use dexamethasone if you wish. We do not use dexamethasone much in the UK or the US, but dexamethasone has the advantage of being a 4-day course, which is obviously better. There are more side effects with dexamethasone than prednisolone, but it's only 4 days. And the main advantage of dexamethasone would be the speed of rise of the platelets is a bit faster, but it's not more durable or anything like that. It's just the speed of rise is quicker. So what do we do after initial therapy for patients nowadays? Well, because this disease is low morbidity and it's low mortality, it's not going to make them sick, it's not going to kill them. I mean, do they really need treatment at all? We're not so fixated on platelet counts anymore. We just want to keep them well and able to do what they want to do without poisoning them with therapy. So do they need treatment? Well, if they do need treatment, what's available that is safe and that they can tolerate? So in terms of safety and tolerability, the older treatments are not great. Immunosuppression, all these drugs, danazol, dapsone, they don't work very well. They have loads of side effects. For safe, tolerable therapies, we're looking more at TPO receptor agonists, which are associated with a good quality of life. And they're very tolerable and they work incredibly well. So you need to discuss the options with the patient. What do they want? What do they do? What's their lifestyle? What's their occupation? Are they at very high risk of bleeding? Or maybe they work in an office. Maybe they're young with no comorbidities and they don't bleed. Then maybe we can just watch for a while. But obviously, if they're older, if they do bleed, especially wet purpura, or they're very high risk of bleeding through their occupation or maybe their hobbies, they like going skiing or snowboarding, then obviously you have to offer some kind of treatment and try to avoid toxic drugs like the old drugs and try and avoid immunosuppression, especially in a pandemic. I think we should avoid immunosuppression anyway, but I think especially in a pandemic, it's a good thing to avoid immunosuppression. So there we are. So I think if you're going to avoid those things, then we're looking more at eltrombopag, bromiplastim, avatrombopag. Those are the drugs which have clearly been associated with a good quality of life. They've clearly been shown to be incredibly effective. They are way better than anything we've ever had before. And I think with those drugs, I don't think we will ever have a class of drug which is as effective and as well tolerated as the TPO receptor agonists. The bar, as they would say, has been set very high with those drugs. I don't think anything will knock them off the place where they are in our thinking, second line, maybe even first line. Over the years, we might start using them first line as well. So just to sum up, big changes in the way we manage ITP over the last decade. The focus is now away from platelets and right on the patient and their quality of life. The introduction of Nplate and Revolade has changed everything, completely changed the whole landscape of ITP. So after failure of initial therapy, which is what we're talking about here, choose a treatment which has high efficacy, low toxicity if you can, avoid immune suppression as well. So that was my final slide, and I will stop sharing now. And I thank you for listening. Thank you.
Thank you, Dr. Drew, for such an informative, still concise presentation. Actually, you finished before time. We have a spare time, but and we already have questions ready for you. We can tackle by the end of our meeting. I would like to remind our attendee we have 25 minutes at the end of the meeting with all panelists to answer all of your questions. So any question that pop in your mind, please feel free and write it, and we'll answer it for you. And now allow me to welcome our second speaker, Dr. Mansour Radwi. He's a consultant of internal medicine and hematology, assistant professor and chair of Department of Hematology. He's the chairperson and academic accreditation and quality assurance unit and Faculty of Medicine, University of Jeddah, Kingdom, Saudi Arabia. Dr. Mansour Radwi will talk to us, as you could see from his first slide. We will discuss management of he will discuss management of ITB in a special situation. Welcome, Dr. Mansour. The floor is yours.
Thank you, Dr. Ayman, for the kind introduction. And I would like to thank the organizers for inviting me. So I chose this special situation is the pregnancy. So thrombocytopenia and ITP management during the pregnancy. So I just want to make sure it's moving. Yeah. So isolated thrombocytopenia in pregnancy is quite common. Up to 1 in 10 pregnancies have isolated thrombocytopenia. And fortunately, the most likely cause for this isolated thrombocytopenia is gestational thrombocytopenia in up to 75% of the cases. However, it's always challenging to distinguish between gestational thrombocytopenia and new onset of ITP during the pregnancy. This is because there's no diagnostic test to differentiate between ITP and gestational thrombocytopenia. As we know that ITP is a diagnosis of exclusion, and it's quite difficult to determine in some circumstances during the pregnancy whether this patient is whether the pregnant patient is having gestational thrombocytopenia or ITP. There's also many clinical features that are overlapping. Although some features are more going with gestational thrombocytopenia and can be can help in differentiating it from ITP, but is gestational thrombocytopenia a benign phenomenon? I know we're talking about ITP, but it is interesting to know that whether there's an overlap between the features of ITP and gestational thrombocytopenia and the outcomes in maternal in the pregnant woman. So, an overview, the pathophysiology of the gestational thrombocytopenia is unclear. There is a hypothesis whether this could be related to hemodilutional or accelerated platelet clearance. Platelet counts do matter in gestational thrombocytopenia. When you have a mild thrombocytopenia, when your platelet counts are between 100 and 150, studies did show that there's no fetal or maternal consequences during the pregnancy or after. However, there could be studies are now coming up and showing that clinically significant gestational thrombocytopenia, which is defined as platelet counts of less than 100, there could be some fetal or maternal consequence. And this was clear in a study that was done in a neighboring country here, where they compared gestational thrombocytopenia count of less than 100 versus newly diagnosed ITP of less than 100. So this was a retrospective study that spanned over 10 years. It included only singleton pregnancies where the platelet counts were less than 100. And the criteria to differentiate between new onset of ITP and gestational thrombocytopenia, they used the ASH guidelines 2011 definition, where you have a thrombocytopenia less than 100, which does not normalize within 12 weeks postpartum. So this is considered to be a new onset of ITP. However, if your counts do normalize, then it's most likely the diagnosis is gestational thrombocytopenia. Now, I apologize. I know the tables are small, but I'm just going to walk you through it. As we know, gestational thrombocytopenia are more likely to present in the third trimester compared with the newly diagnosed ITP, and this was significantly different between the two cohorts, between the gestational thrombocytopenia and the newly diagnosed ITP patients. However, we do realize that about 1/3 of the ITP patients were presenting in the third trimester. There were considerable difference between the platelet counts during the pregnancy. However, the outcomes when you look between the gestational thrombocytopenia and the newly diagnosed ITP, there was no quite difference between the antepartum bleeding and postpartum bleeding in these two cohorts. Also, the neuroaxial anesthesia deferred, so not offering epidural, were also considerably high in gestational thrombocytopenia when your counts were less than 100. Also, neonatal thrombocytopenia was also not different between the newly diagnosed ITP and gestational thrombocytopenia of less than 100. So it's quite remarkable that to see that gestational thrombocytopenia, although initially it was thought to be a benign phenomena that occurs during the pregnancy and resolves on its own, it does have some resemblance to the newly diagnosed ITP. Now, whether the pathophysiology might be similar, or maybe because we're defining gestational thrombocytopenia not quite accurately, and there's an overlap between that some of the cases were more likely to be ITP than gestational thrombocytopenia, that yet to be determined. Now, the interesting fact about the gestational thrombocytopenia is the clinically significant, that when subsequent pregnancies were followed up, again, the recurrence of the gestational thrombocytopenia occurred in around 55%. So it's a disease that is usually, if it happens in one pregnancy, it's most likely to be occur in subsequent pregnancies. Now, there was no significance between the initial pregnancy that had gestational thrombocytopenia and subsequent pregnancy in regards to the nadir platelet count and the onset, rates of bleeding and obstetric complication, as well as neonatal thrombocytopenia and requirement of treatment administration. Now, if you look at the mothers who had gestational thrombocytopenia and see the platelet counts in the neonates, 7 of those, as I highlighted, had thrombocytopenia, the neonates, and 2 of them had severe thrombocytopenia. One had a platelet count of 1, the lowest, and the other neonate had a platelet count of 18. Both of those required IVIG and platelets. Now, this is where I was talking about whether this could be the overlap features between the neonatal thrombocytopenia, the gestational thrombocytopenia and ITP. Those who had complication, whether it was bleeding or they had neonatal thrombocytopenia, they were more likely to present during the first and second trimester, and they were more likely to have bleeding, especially antepartum bleeding. So in conclusion, clinically significant gestational thrombocytopenia, which is defined as less than 100, might behave similarly to the new onset ITP, especially if the gestational thrombocytopenia presents early in the pregnancy. Also, when you have a gestational thrombocytopenia, there's a high chance of it recurring in subsequent pregnancies. Now we move along with the clinical features of severe ITP in pregnancy. Before we talk about severe ITP in pregnancy, just an overview of how ITP presents in pregnancy. So the incidence ranges between 1 in 1,000 to 1 in 10,000. And the truth might be closer to the second number, 1 in 10,000, according to the recent studies. Now we know that the management of the ITP in pregnancies, it depends on the platelet count threshold. So if you're planning to have a vaginal delivery, a platelet count of more than 30 is considered to be safe. If you're planning to have a cesarean section, the platelet count of more than 50,000 is considered to be safe. Anesthesiologists have concern about developing hematoma when they're administering epidural anesthesia. So they tend to prefer counts more than 80, although there are some case reports and few case series that have showed that count of less than 80 might be also feasible. But however, the guidelines currently at this moment recommend the counts to be more than 80,000. Now, ITP in pregnancy is considered to be a low risk, and it has been shown in multiple cohort studies where the mortality in mothers who have ITP who are pregnant is less than 1%. Intracranial hemorrhage in neonates is around 1.5, and neonatal thrombocytopenia is not uncommon. It can be up to 10%. Now, this is a cohort where they followed patients who were pregnant and had a platelet count of 50. This was a prospective study in UK where over the 2 years they looked at pregnancies where the platelet counts were less than 50. And they found that the incidence of severe ITP as defined as 50,000 platelet counts of 50,000 and less was around 1 in 10,000 pregnancies. When they looked at the 107 women who had severe ITP and whether they received any treatment, 22% of them did not receive any treatment, and the rest received either steroids or IVIG or both. Now, when looking at the outcomes, patients who were pregnant, who had postpartum hemorrhage, were more likely to have a lower count of platelet count at the time of the delivery compared to pregnant women who did not have postpartum hemorrhage. Now, the postpartum hemorrhage, if you look at the definition of the routine definition of 500 ml in the first 24 hours, half of the pregnancies did have 500 ml in the first pregnancies, in the first 24 hours. In regards to severe postpartum hemorrhage, which is defined as 1,000 ml in the first 24 hours, excuse me. Around 20% of the pregnancies had severe postpartum hemorrhage. In this cohort, there was no maternal death. Only bleeding was the complication that occurred with the ITP. And in regards to the neonatal outcomes, 7 babies, 12% had a platelet count of less than 100, but there was no intracranial hemorrhage, death, or requirement of treatment. So severe ITP in pregnancy does have consequence, although it may seem to have behave like a low risk where there's no maternal death, no hysterectomies, but it is associated with bleeding and especially postpartum hemorrhage. So we move along to choices of ITP treatment in pregnancies. We know that the first or the initial treatment for treating ITP in pregnancies is the glucocorticoids and IVIG. And there's no, and I looked at the several cohorts and to see whether there was any comparison between whether there was a preference between glucocorticoid versus IVIG and ITP. Obviously, as I outlined, the ITP in pregnancies is quite not common disease, and it's very difficult to do randomized clinical trials to see which one is more efficacious than the other. However, there are three cohorts, two large and one small. Shahad et al., this was a Canadian cohort where they looked at 100 pregnancies with the diagnosis of ITP and a platelet count of less than 100. Overall, the response, there was no difference between patients who received initially glucocorticoid versus those who received IVIG. However, a Chinese cohort, the definition was a little bit different, where they looked at more severe thrombocytopenia in ITP pregnant patients. There was also a considerable cohort, about around 87 pregnant women. And they found a little bit of a difference between glucocorticoid and IVIG. IVIG was higher, the response was higher compared with the glucocorticoid. Smaller Swedish cohort where they looked at 29 pregnant women in a prospective manner. And they found that the glucocorticoid and IVIG, most of the women did respond to the initial treatment. However, just if we concentrate on the Canadian and the Chinese cohort, we do realize that although the response is there, but we are expecting that some women who are pregnant with ITP will be refractory to glucocorticoid and IVIG, even when they are combined. So the problem is going to be determining the treatment in patients who are refractory to the initial treatment.
Dr. Mansour, we have 2 more minutes.
Okay, I'm just about to finish right now. So there are no, there's no clear guidelines in regards to which treatment that we need, that we can use, although rituximab has been used in case series. But however, recently there have been interest in regards to using of thrombopoietin receptor agonists in patients who are pregnant. And this is a retrospective multi-center study that was published, that was presented in ASH last year, where they looked at 15 pregnant women who received either L-thrombopag or romiplastim. And the median time of the exposure was around 4.4 weeks. Three of these pregnancies, three of these women did receive TPO receptor agonists since the start of the pregnancy. And the overall response rate was 77%. Although we don't have a clear, I don't think they have published their full paper, it's only an abstract, but they did say that the treatment was combined with other modalities. But there was a good response in 77% of the cases. More importantly, there was no thromboembolic events among mothers, although there was one case of neonatal thrombocytosis, and we know that the thrombopoietin receptor agonists do cross the placenta. However, but there were, aside from the thrombocytosis, there were no other complications in the neonates. This is a very interesting, this is going to be my last slide, a very interesting study from China, where they used a novel recombinant human thrombopoietin therapy, 31 patients who had ITP refractory to steroids or IVIG were started on this novel recombinant human thrombopoietin agents after the gestation age of 12 weeks. And this is just a diagram to show how they loaded the thrombopoietin agent, and then they adjusted according to the platelet counts. The outcomes were similar to the thrombopoietin receptor agonists, where 74% responded, i.e. their platelet counts rose more than 30 and were twice the baseline. 10 patients achieved a platelet count of 100. Most importantly, the perinatal outcomes, only 9 neonates had platelet count of less than 100, but not severe. No neonate had a platelet count of less than 50, and there was no congenital disease or development delay. So take home message here, thrombocytopenia, especially less than 100,000 in pregnancies, needs close follow-up regardless of the cause. ITP, especially severe, seems to be low risk, but still can be associated with significant bleeding during the delivery. Steroid and IVIG are first line, still are used as considered as the initial treatment, but physicians should expect that some patients would be refractory and they should start thinking about the second line therapy earlier on. The second line therapy, there's no clear guidance in regards to the evidence of which agents should be used preferably. However, it seems to be that the TPO receptor agonists are promising. Unfortunately, for the recombinant human TPO, it's only lies in China despite its effectiveness. Thank you very much. This is my last slide.
Thank you, Dr. Mansour, for your presentation. It's such an interesting topic regarding pregnancy and ITP. Definitely not an easy thing to tackle or treat. Thank you again. And now please join me to welcome our last speaker, Dr. Hazza Zahrani, Consultant Hematology at King Faisal Specialist Hospital in Riyadh. And I'm just gonna conclude this as an introduction based on his personal request. Please welcome me. Let's welcome Dr. Hazza. He will talk to us now regarding living with an ITP for the next 20 minutes. Then we'll answer all of your questions, most of your question here in the question place. Thank you.
Thank you very much, Dr. Iman, for the introduction. It's a pleasure and honor for me to be with you tonight. And I was asked to present a brief overview of 2 articles that were published recently on the impact of ITP on quality of life and on patient perception of diagnosis, signs and symptoms, and treatment thrombocytopenia. This is recently published in February this year. And as you know, ITP patients' preferences and values are increasingly incorporated into the choice of therapies, especially in situations where no high level of evidence are available. And like any other illness, ITP is expected in the patient's quality of life, daily activities, emotional health, energy level, fatigue, and work productivity. So these surveys that were published by Cooper and Dr. Provan is also a co-author in these 2 studies, basically look to what evaluated to what great extent did the diagnosis impact the health-related quality of life and the perception of patients and physicians on the diagnosis and signs and symptoms of ITP. So this was a cross-sectional survey conducted on 13 countries on patients and their treating physicians. Survey was done by invitations, and a steering group was formed. They formulated a questionnaire, collected the data, and analyzed it after the collection. 13 countries were involved in this study, as shown in this map. And they included patients who were more than 18 years of age with the diagnosis of ITP, who were not in the hospital setting. They also included the physicians who had who are treating ITPs and had at least more than or equal 3 active ITP patients, and they were the responsible physicians treating these patients. The survey was made by invitation, which was sent by mass email to the patient support network, and physicians were also were requested to disseminate the survey to patients. Physician survey were emailed from local field work agencies. The steering group was comprised of ITP clinical experts and patient association group leads. So this is what was formulated in a patient survey or in the physician survey: questions on demographics, on ITP symptoms, the health-related quality of life and emotional impact on work, finance and support, and treatment received and patient-physician relationship, as well as the questionnaire on ITP-related quality of life. And this extensive data has been collected. I have selected a few of these issues and I'm sharing it with you. So they included 1,500 patients and they surveyed 472 physicians, and the median length of ITP time diagnosis is around 5 years, and the patient self-reported current health status was reported as being highly impacted with by the diagnosis of ITP, with symptom burden being very high or high in 50% of the patients. Physicians treating these patients are experts and had 7 to 10 years of experience, and mostly hematologists, and newly diagnosed patients with less than the chronic cases. The median time from initial presentation to diagnosis of ITP was around 2 weeks, and the common symptoms are epistaxis, purpura, and bleeding gums. And if you see here, the delay of diagnosis had an impact on 2 other parameters, which are fatigue, which is seen in 50%, and then anxiety around the unstable platelet count, which was seen in 1/3 of patients. Number of physicians treating these patients is a median of 2, but ranged from 1 to 10, and 66% of patients were referred from another provider. In the diagnostic test and misdiagnosis rate in ITP, usual standard ways, but Warner was more likely to be done in patients with high symptom burden, and then to around 50% of patients with moderate symptom burden. 71% of physicians actually believe that up to 1/4 of patients with ITP were misdiagnosed, and the most common misdiagnosis was drug-induced thrombocytopenia in 2/3 of the patients. Patients tended to request or seek support at the time of their early diagnosis, which was seen in 59% in patients who requested and expected support from patients and from family and friends, 50% from physician, and patients also from the patient association groups also. They thought and requested support in 1/4 of the situation. Now, the most commonly reported ITP signs and symptoms were a little different between what was reported by patients and physicians, particularly with regards to fatigue and anxiety, where fatigue was reported in 58% by patients and only in 31% by physicians. And anxiety was reported in 34% by patients. Now, looking at the severity of symptoms at diagnosis and the survey, which is a median of around 5 years, this graph shows you the percentage of patients with or reporting signs and symptoms here, and this is showing you the severity of symptoms. So you see that there is a good fraction of these patients, yes, presenting with bleeding symptoms, but fatigue was reported by 73% of patients at diagnosis, and this also persisted at the end of survey or at the survey completion, which was, as we said, the median of 5 years in 65% of patients. Now, thrombosis and other manifestations were very infrequently reported, around 5% here. But when they are there, they're serious and severe, reported both at the time of diagnosis and in the survey time. The occurrence of and severity of ITP signs and symptoms from the physician's perspective is shown here, where again here this is the percentage of patients reporting symptoms, physicians reporting the severity of this manifestations, and this is the percentage of patients with the. So fatigue was reported by around 59% of physicians, but they thought the severity was in the range of 30%. And physicians tend to focus more and concern have more concern about bleeding manifestations like pica, purpura, bleeding gums, epistaxis, and menorrhagia. When fatigue is present, the physicians thought it was severe and significantly impacting the patient's life in almost 50% of patients, and moderate in around 27% of patients. And this seems to be correlated with the severity of thrombocytopenia, where it was highest in patients with lower platelet count. Now, with regards to the treatment prescribed by physician following relapse ITP, is first line of relapse. Yellow is second relapse, and blue is the third relapse. You see that at the second and third relapse, the most commonly prescribed medications were thrombopoietin receptor agonists or rituximab, like what we commonly do in our clinical practice. The reasons for change of therapy from physician's perspective is lack of efficacy in almost 90% of situations, and disease worsening or treatment-related side effects in 3/4 of patients. Sorry. Now, cost was also another reason to shifting therapy in 1/3 of patients. The prioritization in choosing treatment, comparing patients and physicians, were very similar. Basically, both requested or were trying to prioritize having a remission, a reduced bleeding risk with the least side effects, and as Prof. Krogan was showing and telling us in the presentation, avoidance of immunosuppressive therapy was a major goal in patients. The impact of ITP on functional aspects of health-related quality of life is shown here, where 75% of patients reported that ITP had an adverse impact on their ability to perform their daily tasks, where you see here their energy level, the capacity to exercise, the daily tasks, their working life or impact in studies and concentration on everyday tasks, hobbies, social life, and being off work or off education, and requesting support by other people are all impacted and obviously seen in most of the situations. And sometimes all the time, these symptoms are present. So 42% energy of the patients reported a reduction in their energy level, and 1/3 of patients reported reduced ability to do exercise, and other aspects were shown up to 1/4 of patients. The negative impact of ITP on functional aspects of health-related quality of life was seen in 70% of cases, and affecting the social life in around 60%, affecting sexual life, and 39% of patients who had high or very high symptom burden at diagnosis. And those were almost all of them have less energy due to the ITP. The impact of psychological and emotional well-being from the disease was also very obvious, where 50% of patients reported that ITP had a negative impact on their psychological and emotional well-being. They worry about their overall health. They worry about the platelet count going up and down, and having a stable and safe platelet count, feeling stressed about the ITP condition, and the worry about dying from the ITP. And also the worry that their physicians may not think that appreciate how severe their illness is. Also, they worry about the physical appearance, and some wear long sleeves to cover areas of bruises and other symptoms and signs related to the disease. Now, this concern of dying from the disease was present both in females and males, and also younger and older patients. And 41% of patients were worried about dying. And physicians, almost 50% of them felt that their patients were worried about dying from ITP. Now, the effect of ITP on work and on activities is shown here, where 50% of patients have reduced their workload, and 29% of them consider termination of their job. And 43% of patients thought that ITP had affected their regular activities outside the working hours. And ITP has negatively affected productivity at work of employed patients, especially in those with high or very high symptom burden in 1/3 of the patients. And 11% of patients stopped working, or their employment was terminated because of the ITP. And this is true for both males and females, and for younger and older patients. And overall, 43% of patients have an impact of their ITP on their day-to-day activities. This is the patient's reported outcome. And also physicians, 50% of them had an impression that ITP has a negative impact on patients' ability to undertake their daily activities like preparation, household gardening, childcare, and oral hygiene.
2 minutes.
Yeah. Regarding satisfaction of with treatment, almost all treatments were satisfactory in 70 to 80% of patients, but the satisfaction for splenectomy was lower, being only around 38%. The relationship between physicians and patients were reported to be satisfying in 75% of the patients. And physicians thought that they are satisfied with the ease and convenience of prescribing medications and with the treatment goals they have wanted in 80 to 90% of their situations. This is somehow a repetition, but to conclude, I think the major concerns highlighted by both physicians and patients are the fluctuating platelet count, the fear of worsening of disease and dying, the impairment of social and sexual life, the desire to avoid immunosuppression, and also the fatigue is felt by patients more than what is perceived by physicians. And patients indicated the need for considerable support, highlighting the importance of the patient association group, which is lacking in our region. I think the IWISH study or survey utilized excellent comprehensive tool to assess the patient experience of ITP. The use of disease-specific patient-reported outcome measures can help to promote more uniformity across studies for evaluating how patients experience ITP. And thank you very much for your attention.
Thank you, Dr. Hazza, for your informative lecture. Your presentation reminded me of one of my patients who was diagnosed as an ITP while he was just kicking off his career as a professional football player, and it was devastating news for him. He was so terrified that his career is ending. Would like to thanks Novartis for unrestricted support to conduct this webinar, and would like to invite our panelists to join for answering the question. We have up till now 22 questions. Hopefully we'll have in the next 20 minutes time to answer them, and I would like to remind our attendees they can post their question in question and answer icon here, and we'll do our best to answer them if it wasn't answered already. I'll start with the first question was posted early in the meeting. How to treat refractory thrombocytopenia secondary to antiphospholipid syndrome in the presence of a thrombosis, i.e., would you like to use anti-TPO agonist? Dr. Drew, what do you think?
Yeah, that's a good question. That's a good question. And I think, well, if someone has antiphospholipid antibodies, then I think I would cautiously consider a TPO receptor agonist. If there was nothing else available, and I think in today's pandemic, it may not be unreasonable, but if someone has antiphospholipid syndrome, which is different to someone who just has the antibodies, if they have the syndrome, I would avoid a TPO receptor agonist, because thrombosis obviously is a risk of the antiphospholipid syndrome, and you may just tip the patient into a thrombotic event with your TPO receptor agonist. So yeah, avoid in the syndrome. Consider maybe if they have the antibody, maybe.
Yes, actually, Dr. Zaid wanted the case to be much more difficult, and he said antiphospholipid syndrome in the presence of thrombosis. But all are there.
Yeah. That's right. Yeah.
Thank you. There is a question regarding children age of 13. Whoever is experienced with this age group, please. Let's answer this question. A patient, children with an age of 13 with an ITP not responding well to steroid. And in case of Fanconi anemia, children with low platelet, what's the best? It's a bit beyond.
Did you say Fanconi anemia? No.
Fanconi, yeah. So the two questions, patient who's 13 not responding to steroid as an ITP, and in case of Fanconi anemia.
Okay.
Yes.
I mean, I think if you look at the TPO data for children from the PETITE study and the other pediatric studies, these are very nice drugs. I think if the child required if the child did really require therapy and could not be watched and waited on, then a TPO is a good choice, good quality of life. It's not immunosuppressive. Fanconi, I have no experience. It's like a form of aplastic anemia. It's bone marrow failure. I don't know many patients worldwide who have been treated. It may well work. Maybe my colleagues on the panel may know more than I do.
Dr. Hazard, Dr. Mansour, if you have an experience in such a scenarios.
We anecdotally have used TPO agonist as a bridge for definitive therapy. But as Prof. mentioned, the ultimate therapy is transplant for these patients. And if there is, sometimes they do respond, especially from anemia point of view, to steroid therapy. So generally, we may use it for a short time in case of severe cytopenia. But in general, the usual treatment is transplant.
Dr. Hazza, we're losing your voice sometimes.
I'm sorry.
So you're saying most likely for Fanconi, the treatment of choice would be transplant.
Yes, in typical classical Fanconi, allogeneic stem cell transplant.
So Dr. Hazza, there is a question, can HET present in patient with ITP if they are on heparin?
This can happen, but I have never faced this. Most of the time, I don't think of HET in the setting of, an ITP in the setting of HET. It could be a situation where you have a de novo hit or antiphospholipid antibody related, hit-like manifestation, and these patients are treated in a similar, if they don't have thrombosis. We have seen anecdotal cases of de novo hit, and these days we have the vaccine-induced thrombocytopenia or thrombosis, and this has, I think, the two clinical, scenarios of where you treat as both hit and treat with immunosuppressive therapy for immune-mediated thrombocytopenia.
Actually, Dr. Azza, we have a question regarding how can we deal with ITB that may occur with the COVID vaccine?
I think it would be treated like any ITP patient, basically with, depending on the severity. So if the patient has no, or the platelet is above 50 and there is no bleeding, we would not treat. Above 30 also, if there is no procedures or bleeding, maybe you can consider observation. But if it is very low or there is bleeding, we would consider steroids and IVIG, and typically most of these patients would be in dexamethasone already.
Okay, thank you, Dr. Hazza.
Dr. Provan, do you have any comments on this?
No, I agree with what you're saying. We don't use dexamethasone, but I agree with you. Steroids, treat them like ITP. Yeah.
As we are asking about the thrombocytopenia with the COVID-19, what are your experience? Have you seen such cases? What is the lowest count you've seen after the vaccine?
Is this for me?
For you, Dr. Drew, and also for Dr. Hazza, Dr. Mansour, if you've faced such scenarios.
We've seen some quite low platelet counts associated with the vaccine. We see, the COVID vaccine is a vaccine. We see it with lots of vaccines, but we've seen it also with the COVID vaccine and quite low counts in some patients. Nothing terrible, no bad outcomes so far. But we have to treat them seriously and obviously reassure them and manage them, as we've just discussed, either watch and wait, depending on how low the platelet count is, and also the symptoms that they have and the signs. Obviously, take each person as they come, each individual patient.
Dr. Drew, there's a question about the criteria to discontinue TPO agonist in patients with ITB.
Yeah, no, that's a good question. I think we used to think maybe after a year, but I think the consensus from the panels which have discussed this, there's a nice paper by Francesco Zaya in Blood Reviews last year. I think wait for 6 months. Don't consider it before 6 months, but if by 6 months the patient has a nice stable platelet count, maybe not on the full dose of a TPO receptor agonist, with a nice count of above 50,000, then you could consider tapering. The reverse would be someone who does not achieve 50,000 platelets, or who needs a big dose of either romiplostim or Revolade, maximum dose and not a great count, and instability, unstable counts, then probably don't try to taper. But you tend to know fairly quickly which ones you can taper. They respond fairly quickly to the TPO receptor agonist. They maintain a nice stable count. They go well above 50, and you just know they're probably going to be able to be tapered later. But we do give them at least 6 months.
Actually, there's a question similar to that regarding when to discontinue. They were asking if there is a maintenance dose before considering tapering.
No, most of us that we've tapered, for example, Revolade, they're usually on around 50 milligrams a day, and then we switch them to 25 milligrams, and then we wait maybe a month, and we see if they're okay. If they're still okay, go down to 25 milligrams every other day. And then if after 1 month like that, we do 25 twice per week. And then after another month, we usually stop.
Okay. Thank you, Dr. Drew. Dr. Hazza, there's a question about the risk of thrombosis with the use of romiplastim in comparison with splenectomy. And would you consider it in a patient who has an ITB and history of thrombosis?
Thank you. So the risk in the literature is around 5% with regards to TPO agonist. And for splenectomy, it is higher, I think reaching up to 10%. And in our practice, we use prophylaxis for 6 weeks using Clixane. And if they still have persistent thrombocytosis after, if they do have a response and have persistent thrombocytosis, I personally tend to give them aspirin for some time until the platelet levels. But the question is on its use in a patient with history thrombosis. If I am stuck and I cannot have any other choice, I might consider it after a detailed explanation to the patient and have a shared decision.
Okay, thank you, Dr. Hazza. Dr. Hazza, are we hearing you or we lost your voice?
Sorry?
I thought we lost your voice.
No, did you hear my answer?
Yes, thank you, Dr. Hazza. Dr. Mansour, we have a question. What percentage of patients will achieve remission with initial treatment, and who will never need a subsequent line?
Do you mean during the pregnancy?
They didn't mention. I think they mentioned in general. They mean general patient with ITB. How many percent will never require a subsequent line of therapy?
In regards to the in regards to the response, I think it's around 60% with the initial treatment. I don't have the number right now in regards to the success to the patients who can taper off with the initial treatment. Maybe Dr. Provan can provide us with that number. But I think that's around that's for the initial treatment that and their pregnancy is quite lower compared to the non-pregnant cohort. As I outlined, the pregnant women would tend to have around 40%, maybe 50% response with the initial treatment, but most of the time they will require some form of combined therapies and even moving on to the second line therapy.
Dr. Brovin, what's your comment regarding percent of patients who will never require a subsequent therapy?
Well, I think if you look at patients who present with ITP initially and then they go on to something like corticosteroids, prednisolone, for example, around 80 to 85%. And around 85% usually respond. But the problem is most of them will relapse when the steroids are tapered. And I think long term, with no other therapy required, would be around 15% probably. So the majority of people who have initial therapy will require subsequent therapy. That's the problem. So steroids are great and they work for most patients, but they also, most of them relapse.
Actually, there is a similar question about giving a patient a steroid or IVIG as an initial therapy, and then the patient relapse. Would you consider restarting steroid, recharging them with steroid or IVIG?
I think one thing we've tried to stress in the guidelines, I think probably the ASH and the consensus, is this concept of steroid recycling, where you keep using steroids again when they relapse. It just causes problems and stores up lots of problems for when they're older. So one course of steroids, and if they relapse, they could use something else. We tend not to use steroids again. Sorry, what was the second part that you said? I've forgotten.
That's the question. If we give the patient initially steroids and IVIG, then they relapse. Can we consider them again for the same
No,
line.
I think not, and especially nowadays, we use a TPA receptor agonist if they fail steroids, and that's been sanctioned by the English and Welsh health service here. We've got an interim approval for using TPA receptor agonists in newly diagnosed. So that's what I would use at the moment in this, especially during the pandemic. Not more steroids, not more steroids.
Thank you, Dr. Joe. Dr. Mansour, actually, there is a question if a patient, a young woman with a chronic ITP, refractory to steroids, post-splenectomy, but she's responding to a Thrombo bag and she wanna get pregnant, what would be your advice for her or management?
So she is she had already had a splenectomy and she did not respond to it. This is the question. And
she's already responding only to a Thrombo bag, but now she want to get pregnant while in a Thrombo bag.
Yeah, it's a tough question. It is thrombopoietin receptor agonists do cross the placenta, so there is a concern, and there is no safety data in regards to using it in pregnancy. I'm definitely going to advise the patient not to get pregnant. If she is planning to get pregnant, we have to see whether she's responding to the steroids or IVIG. Explain to her the risk and the benefit of getting pregnant if she is truly refractory to the steroids and IVIG. If she is responding to the steroids and IVIG, but because she's relapsing, so that could be used initially and keep her on the steroids and IVIG as much as possible. Maybe at the end of the pregnancy, we can use a TPO mimetic just to get her get the platelet counts up for the delivery. Obviously, it's a complex situation, so you need to know what are the counts off the TPO if you're going to stop the TPO mimetics, and if it really drops. If she does hover around 30s and 40s and she's not bleeding, so we can stop the TPO receptor agonist and see if she's having any complications. If she does require any rescue treatment, then you can start steroids and then use an IVIG. If she's refractory, then you're going to put her back again on the TPO receptor agonist. So it's a complex situation. You need to know what the counts are, if she's bleeding or not. She has a history of responding to the initial line of treatment, and then decide on, and then counsel her and tell her what to do, what are you going to do during the pregnancy.
Thank you, Dr. Mansour. With the time now, pandemics, so many talks about everything associated with COVID-19. Dr. Hazza, if you can help us to answer this question, can TPO continued in view of patient having, in fact, having a COVID-19 infection with the concern of a thrombosis with the COVID plus the TPO? Can we continue the treatment?
Yes, so this is a tough question. I think it's a balance between the two risks. And, TPO agonists increase the risk of 5% or 6%. And COVID-19 increased the risk of thrombosis. DTL, that also adds to it if the patient is also in the ICU or have a procedure or have a line inserted. These all increase the risk of thrombotic complications. So I think a decision will be individualized with a tendency to be avoided if the platelet count is at the safe level. Luckily, I haven't seen such a scenario. Maybe Dr. Provan can comment if he has seen any case.
I will say that we published something in the British Journal, I think it was around May of last year, in response to calls we were receiving from physicians and from patients about COVID-19 infection and what to do in the pandemic, and our recommendation was that if someone was proved to be COVID-19 negative, you could and you would consider a TPO receptor agonist. But if someone was diagnosed with COVID-19 infection confirmed, then we would avoid a TPO receptor agonist because of the risk you just mentioned, the thrombotic risk associated with COVID itself, added to or added by the TPO receptor agonist together is too much probably. So we recommend IVIG, a small dose of steroids, tranexamic acid, for example, rather than a TPO if they're COVID-19 positive.
I think the question is in those who are ITP and they are on TPO agonist and they are admitted
They
with
got
COVID.
infected with COVID.
Oh, I see it. Oh, admitted with yeah, well, that's difficult. Well, yeah, we haven't had one of ours infected, but I guess, I mean, COVID-19 thrombosis, if they're admitted to hospital, then they may end up on intensive care and may end up with a thrombosis. I would be slightly nervous if they're on a TPO. I would probably withdraw the TPO, I think, just for safety reasons, I think. But that's just a guess.
Thank you, Dr. Hazza. Thank you, Dr. Drew. Actually, Dr. Drew, we have this question from two different audience. They're asking about the role of Velcade and or daratumumab in patient with refractory ITB who failed 5 lines of therapy. Seems they share the same care of case. So what do you think of refractory cases for even 5 lines?
I think I have no personal experience, although we have treated one patient, not me personally, in our hospital with Velcade, and it did work. This is very resistant ITP, and we got approval. Our problem is getting approval for non-licensed therapies for ITP is very tricky, and Velcade and daratumumab they're not usually prescribed by us, so they don't let us use it. Daratumumab, I have heard anecdotally, has worked for some patients, but again, I haven't got real experience of using it. Theoretically, it should work, but the real world experience in ITP is quite limited.
Okay, thank you, Dr. Drew. There's a question regarding what to do with a patient if we don't have TPO, but still the patient is failing therapy, steroid, initial therapy, subsequent therapy. What would be an alternative if we don't have TPO as an option?
Maybe I'll just start. Maybe what we used to do, and often sometimes still do, although not in the pandemic, is there's mycophenolate is really nice drug. Rituximab is there, of course, maybe for younger females and below the age of 40, but mycophenolate, we've had great results from mycophenolate before COVID, and we still have some patients on mycophenolate during COVID who were on it before the pandemic struck. Nice drug, well tolerated, very few side effects, a nice response rate, maybe 50% respond. And some of those can be weaned off, tapered after 1 or 2 years, and they maintain a good count. So I quite like mycophenolate in that setting.
Oh, okay. Thank you, Dr. Drew. Dr. Hazza, there's a question regarding patient with an H. pylori positive. Can we treat them if they have an ITB and that would be enough for them? Is that enough to recover their platelet count?
Yeah, I think in patients with refractory ITP, we tend to try eradication of H. pylori. There is a very wide range of, I think the serotype differ from one region and one geographical region to another. So that's why there may be more response in Southeast Asia than in the West. And in our region, I haven't ever seen, honestly, any response to eradication of H. pylori. But in someone who's refractory and have symptoms, we would always try to eradicate H. pylori because of the symptoms. I doubt that it will really change the outcome. That's my answer.
But you won't think of it as an initial therapy when a patient presents initially with an ITB?
If they have symptoms, I would for GI symptoms, not specifically for ITB.
Okay.
GI symptoms, I mean.
I think we are up to time, 11:30. I hope we answered most of the audience questions. There are a few that we didn't have the time to answer, especially for pediatric age group. Maybe we can just answer one last question, Dr. Drew, regarding any data about clonal hematopoiesis after prolonged use of TPO agonist in case of ITP. Especially that reported after their use in severe aplastic anemia.
Yeah, I think these are very different diseases. Aplastic anemia and ITP are so different. And ITP is not in any way malignant and does not transform ever into anything malignant. And there has been no evidence to date of any clonal hematopoiesis in ITP that I've seen or am aware of. Now, we've used these drugs for 10 years or more now, with no one ever reporting that. So it's very different to aplastic anemia. I would not worry about using it in ITP long term. You're not going to induce anything.
Thank you, Dr. Drew. Thank you, Dr. Hazza, and thank you, Dr. Mansour. We're already 11:31. Very interesting topic, presentation and discussion. Really appreciated. I'm sure all our audience and hope enjoyed and found this meeting fruitful. We would like to thank Novartis again for unrestricted support to conduct this webinar, and would like to thank you all for attending. Thanks our speaker for their presentations and discussion. And of course, we'll thank the Saudi Society for Blood Disorders for organizing such a beautiful and fruitful meeting. Thank you all. Wish you a pleasant day or rest of the night. Thank you.
Thank you. Thank you very much.
Thank you.
Thank you very much.